vertices of the skull. But it shows soft tissue pathology very well, and I love to show this particular cut because we can see very nicely the aqueous and vitreous humor. We can see and outline the lens of the eye. We can see the orbital fat surrounding the ocular nerve. We can see the extraocular muscles also surrounded by fat. We can see fat outside the muscles of mastication, the white matter and the dark matter of the brain, pineal gland. We can see a number of things very, very nicely in an MRI of a soft tissue nature. So here we have a patient sent to me with some problem with the mandible. I took a Panorex, and something vague is happening here. It's not very well seen. It's hard to know exactly what's going on. So I order an MRI, and we see surrounding the ramus of the mandible, which is here, this tumor turned out to be a chondrosarcoma. Here's the normal side. But we can only see it nicely with an MRI. Likewise, we sometimes use MRI for imaging the TMJ. So this patient was sent to me with painful popping of the TMJ, got a CT scan, and as you can see, it's pretty normal. We have a nice, smooth, round, well-corticated articular surface of the mandibular condyle, likewise of the glenoid fossa. There's no osteophytes, there's no other abnormalities in the CT scan. What to do? What do we tell the patient? The patient has painful popping. Do I send the patient home and say you're normal? Well, no, I ordered an MRI, and the MRI shows the true pathology. Here is the disc, and it's dark because cartilage has no blood supply, but the disc is anteriorly displaced. Okay? We can also see the lateral pterygoid muscle attached to the head of the condyle. Bone detail is not very good, although we do see the white bone marrow in the center of the condyle, and in black we see the cortical bone, again nicely corticated as we saw in the CT scan, although we wouldn't take an MRI if we wanted simply to look at good bone detail. We'll go back. The CT scan is much better for that. Now, there's a couple of types of MRI scans that we can look at. Your standard MRI scan is called the T1 scan, and it has to do with the physics of the scanning. But in the T1 scan, fat, such as in the bone marrow within the inner table of the skull, or orbital fat, appears white. Fluid is dark, so cerebral spinal fluid is dark. Inflammation is dark. We also, in most patients, do a T2 scan. And the T2 scan highlights fluid, makes it white. Also makes fat light gray. And since inflammation has a lot of fluid, inflammation is white. Okay, so we see all these things in a T2 scan. We can also do contrast scanning with the MRI. And we use a drug that has a solution of gadolinium. And
Gadolinium is a metal that has paramagnetic properties, so the solution allows vascularized structures to light up. So we can see blood vessels within the brain here. This is endon, for instance, and this is the side of the blood vessel. Okay, but we also see enhancement of areas of inflammation, and we see enhancement of tumors, because tumors typically have more blood supply than the adjacent normal tissues. And lo and behold, we see this area at the back of the brain, and this is a meningioma, a common brain tumor. Okay, and this is really highlighted by the contrast scan with gadolinium. However, if we go back, you can see in the T2 scan, it was there. It just didn't pop out at us. Likewise, in the T1 scan, it was there, okay? But it shows how, oops, wrong direction. It shows how the contrast MRI is very helpful to us in diagnosing certain lesions. Again, as dentists, we won't be looking at the brain, but I show these brain studies because I think the brain and skull really show the usefulness of the MRI extremely well. The other type of imaging that we use is scanning. And when we do a scan, we inject a pharmaceutical that has a radioactive tracer in it. And we use a tracer that's taken up by the areas that we want to look for. Usually, tracers are taken up non-specifically by areas where there's increased metabolic activity. And there can be increased metabolic activity in tumors and infections. But we have to be careful because, for instance, in young people, activity in areas of active growth. There are a variety of scans. The ones most typically used are bone scans, which are selectively taken up by bony tissue, and the PET scan, or the positron emission tomographic scan, which is very typically used for tumors, although again, it's non-specific. So we can see in this patient, there are multiple dots throughout the skeleton, and unfortunately, this is a patient with metastatic cancer, which spread to multiple bones. But again, you have to be careful because you also see uptake in both kidneys, and a lot of these tracers are excreted in the urine, so you will get uptake into kidneys, and you don't want to be fooled. So here's a patient of mine with a tongue tumor, and you can see this grayish area on the patient's left side as opposed to a darker area on the right side. That's the tumor mass. In addition, in the neck, there's a large lymph node, whereas there's none on this side. But these areas are vague. They're not very well seen in the CT scan. So I ordered a PET scan, and with the PET scan, these areas really light up and become very, very obvious. So this is a very common type of scan we use to follow cancers and to look for cancer recurrence and to look at areas that aren't as well visualized in other types of imaging. Now, we'll go back to the jawbone because there's a number of characteristics in bone lesions that are important for us to look at when we see an X-ray. So if we see this sort of X-ray of the mandible, we see a well-defined unilocular radiolucency. It's a little bit corticated, and a number of lesions can produce this. You've been through this, and I'm not going to belabor it. There are also poorly defined radiolucencies like this, so that it's not corticated and kind of fuzzy. We'll revisit this when we speak about cancer in an hour or so, but these are often more serious types of lesions, and we have to be aware of the poorly defined radiolucencies. We also have multilocular radiolucencies. And more poorly defined multiple radiolucent lesions. Radiopacities, we have discrete lesions like this large osteoblastoma, and multiple or diffuse lesions, such as this patient with florid cementoosseous dysplasia. There are mixed lesions. This is a patient with some sort of amealoblastic odontoma, as I recall, but some areas are radiolucent and some areas radiopaque. Enough of that. I'm sure you've had that ad infinitum in other talks. Blood tests are used in some cases. They are rarely diagnostic, except really for two types of cancer. Only one is a head and neck cancer. The parathyroid hormone level is increased in some types of adenomas of the parathyroid gland in the neck. And then there's the prostate-specific antigen, the PSA, for prostate cancer in older men. There are a number of markers of bone metabolism, such as calcium, phosphorus, alkaline phosphatase, and others, which can point to certain diagnoses and which we look at in some cases, although they are not diagnostic. And then there's a whole evolving area of looking for immunologic markers, and they can be elevated in some cancers. And this is an active area of research. I think some of it's actually being done at the dental school right now, looking for markers for head and neck cancer. Right now, there's nothing that has any clinical usefulness. HPV antibodies are elevated in certain types of oral cancer. We'll get into that later. And Epstein-Barr virus antibodies are elevated in I'm blanking on the cancer, but it's also a head and neck cancer, but we will we'll get into that. These are kind of specific, although not diagnostic. Carcinogenic antigen, CEA, is elevated in certain cancers. Alpha-fetoprotein likewise, but these are not diagnostic either. They can be helpful if you have a cancer that you know is positive for an immunologic marker. Then you can use these markers to follow treatment or looking for recurrence of the cancers. So they can be useful in certain instances if you know the patient has a tumor positive for the marker. Getting beyond these non-specific things, making a definite diagnosis really requires tissue. And for tissue diagnosis, there are two possibilities. The first is fine needle aspiration. And fine needle aspiration is something that's been made a lot easier by a very clever guy who developed this pistol type of apparatus that allows you to pull back on a syringe by pulling back on the trigger of the pistol. But you can see it here. So if we go to the right side, these are my fingers, which are holding a neck mass on my patient. And here I am putting the needle into the mass. Oh, sorry. And I withdraw. And if you get into it, you can get a very small amount of fluid. Some lesions more than others. This is actually quite a lot. Sometimes you just get a spray of fluid. But what you do is you put it down on a microscope slide. You take a second microscope slide and you put it on top of it. Why am I doing that? Put it on top of it so that capillary action causes the fluid to spread out. You drop it in a little vial of absolute alcohol to act as a fixative, and you send it to the pathology department where it is read by a cytologist. The cytologist is a pathologist who specializes in reading these cytology specimens. Most of their day, they're looking at pap smears, but they're also looking at fine needle aspirations as well. And the fine needle aspiration allows us to see the cells, and we can very, very easily differentiate benign looking aspirates like this one from ones like this one, which have a lot of nuclei with nucleoli and nuclear chromatin, large and variegated nuclei rather than bland repetitive ones as we see on this side. Sometimes we can get a definite diagnosis, sometimes not, but we certainly are able to tell benign from malignant. We can tell a lymph node that's a reactive lymph node from infection from one that may be caused by cancer. A definitive diagnosis, however, one that we can use for treatment planning, comes from a true biopsy. And a biopsy like this one, where again we see nucleoli, excess nuclear chromatin, nuclei of different size and shape, very typical for a carcinoma. Several types of biopsies. I know you've had a lecture about this. I'm not sure what's in it, but it's appropriate for you to see this in this talk. The excisional biopsy can be useful because for certain types of lesions, especially very benign lesions, there can be simultaneous biopsy diagnosis and treatment of the lesion because you excise the whole thing with a normal margin, as you see here. Keep doing that. So you excise the whole thing, and then you have an elliptical excision, which you could suture and make a straight line scar. Okay, so if it's a completely benign lesion, you've treated it at the same time. A very useful sort of thing for many lesions. However, some lesions are too big to do that, such as this area on the tongue, which shows extensive leukoplakia. And for lesions like this, we have to do an incisional biopsy. We take, again, a wedge-shaped biopsy going through the epithelium down into the muscle of the tongue, so we get a full sample, not just a superficial sample, to send to the pathologist. And then we can again suture this as a straight line. Depending on what it is, it might need more treatment. Another type of biopsy that we use occasionally for exophytic lesions is the shave biopsy. And here we use a scalpel or even a razor blade to excise the exophytic portion of the lesion. It's for very superficial lesions. The base we would typically cauterize so we don't have to suture it. This is done very quickly. There's very little scarring, and it also can be very helpful in a number of areas. So, once we've diagnosed, we have to treat. And the rest of this portion of the morning will be about treating benign lesions. By the way, any questions, anybody, before we start on treatment? Okay. So the first type of benign lesion we'll speak about is probably the most common sort of lesion we see in the jaw bones, and that is the cyst. Mandible is a bit different from maxilla. We have a number of factors to consider, certainly size. So the unilocular radiolucency I showed you before would be treated very differently from this radiolucency, which is quite large because of its size. In addition, because of the size, we have to consider the relation to adjacent normal structures. In this case, the teeth and the inferior alveolar neurovascular bundle, which runs right through it. Keep doing that. Also, for lesions that are up in the ramus of the mandible, we have to consider whether there might be some involvement of the temporomandibular joint. We have to consider the aggressiveness of the lesion, how rapidly it's grown, whether it's gone through the lower of the border of the mandible, as here, or the upper border of the mandible, or caused resorption of the teeth. And we have to assess in treatment, rehabilitation, and the need for reconstruction. Certainly a lesion like this one, if we were to remove it as treatment, it would need reconstruction. You couldn't leave a little eggshell of mandible behind. For one thing, it would probably fracture in doing the surgery. So reconstruction is very important in certain lesions. Likewise, for the maxilla, we have similar considerations. Size, relationship to normal structures, teeth, nasal cavity is in this case, or sinus cavity if it was more forward, or to the base of the skull if it was, more posterior, or base of the skull if it was really posterior. Aggressiveness, and again, need for reconstruction. And finally, we have cysts of the soft tissues, a different kettle of fish from bony lesions. Size, again, is important. Relationship to adjacent structures, such as the eye in this case, just an elliptical excision, and suturing this together may pull the eye across. Same thing with this cyst, may pull the eye in. And relationship to adjacent structures. So this floor mouth cyst has a relationship to Wharton's duct, relationship to the sublingual gland, to the lingual nerve, and certainly something like this, less of a concern, except for the scar, which can be hidden in this normal skin crease. But these are soft tissue cysts that an oral surgeon who has an extended practice might see, and these are the considerations we have to make. So, back to cysts of the bone, the most common ones that we treat, and the gold standard treatment of choice for most bone cysts is the enucleation. Enucleation is possible because there is a fibrous capsule surrounding the pathologic cystic tissue, and the cyst can be removed in a single piece by separating that fibrous capsule from the surrounding bone. So the pathologic portion of the cyst is completely removed. Well, let's go. So here's our patient. You'll note that there's an impacted tooth. The inferior alveolar neurovascular bundle goes through it, although it's typically moved aside, and it gets close to the lower border of the mandible. Here we are immediately after surgery, and as is typical in these cases, there appears to be more bone now, and that's because surrounding the cyst, we retain buccal and lingual bone. We go a few months down the line, here's 6 months, and this has completely filled in with bone. So we've done biopsy and the definitive treatment in a single surgery, almost like an excisional biopsy of a soft tissue lesion. The nice thing is we can send the entire lesion to the pathologist for examination. The reason I mentioned that we'll get into in a little bit. You can also see that this fills in very, very nicely without a bone graft. Although there are surgeons who will throw in a bone graft, but you can see it's unnecessary. Now, there's no free lunch. The disadvantages to enucleation are that you can possibly injure the adjacent normal structures. The inferior alveolar nerve in the mandible, adjacent dental and periodontal structures, and in the maxilla, nasal or sinus cavities. In certain areas, enucleation may be technically difficult. If the mandible is very much weakened, enucleation can lead to a pathologic fracture of the jaw. Pathologic fracture is a fracture that's not caused by typical trauma that causes most fractures. And in addition, in order to do an enucleation, like the patient I just showed you, you may be required to remove teeth that you would otherwise want the patient to have and to use. In some cases, we combine enucleation with curettage. Curettage means removing bone beyond the periphery of the enucleation. And we can do this with either a burr or with a sharp curette. And this allows us to also remove epithelial cells that are in the bone marrow beyond the obvious periphery of the main cavity that remains after the enucleation. It decreases the risk of recurrence, especially in cysts that have already recurred, so we know biologically they are aggressive cysts, or in the case of odontogenic keratocysts, which are known to have a higher recurrence rate than most cysts. However, the curettage does increase the risk of damage to those adjacent structures. So we have to be careful about doing it. In some cases, instead of doing a mechanical curettage, we would treat the cavity that is left after the enucleation with either physical or chemical treatments, which are meant to destroy these epithelial cell rests. Many people like to use cryotherapy, usually liquid nitrogen. However, good studies show that it's only moderately effective in reducing recurrence. Chemical coagulation works better, and the best thing was always a solution called Carnoy's solution. Carnoy's solution had 90% or more effectiveness. However, Carnoy's solution contains 30% chloroform, and chloroform is now banned by the FDA, medical grade chloroform. We can't use it, and therefore we can't use the original Carnoy solution. A modified Carnoy solution has been developed with different solvents in the solution, but it's not very effective at all. There are things called sclerosing agents, which have been used, but they're variable because there's a lot of side effects in normal tissues they may touch in the oral cavity. Fortunately, in recent years, we've started using 5-FU, 5-fluorouracil, which is a chemotherapy drug, and there is a 5-FU ointment which is used for skin cancer, and the dermatologist gives the patient a tube to take home with instructions to put it over the skin cancer a couple of times a day, and it's very effective with certain mild skin cancers and obviates the need for surgery in some cases. And we started using this following enucleation of these cysts with a high recurrence rate. And with odontogenic keratocysts, there have been a number of studies, and thus far, the studies show them to be 100% effective. Now, I always worry about 100% in medicine, but the studies thus far have not shown recurrences with 5-FU. What we do is we enucleate the cyst, and then we impregnate some gauze with 5-FU ointment, and we pack the defect with the gauze, suture mostly just leaving the end of the gauze sticking out. And we leave it in for about a week, then have the patient back in the office and remove the gauze with the 5-FU, and then allow the wound to heal. And it's been very effective. Enough said. Another treatment that we use frequently for certain cysts is called marsupialization. And marsupialization refers to creating a surgical window between the cyst and an adjacent body cavity. In oral surgery, this is typically the oral cavity, but it also can be the maxillary sinus or the nasal cavity. Those of you who are perceptive will understand that the term marsupialization comes from the word marsupial, like a kangaroo, and it's like making a pouch that a female kangaroo keeps her young in. So we take off the top of the cyst and the overlying epithelium, and then we suture the wall of the cyst to the wall of the adjacent epithelium. And we create a little pouch like a kangaroo's pouch. Okay? We do this for a number of very good reasons. Number one, if we're very close to adjacent normal structures that we don't want to injure. Number two, if we have teeth in the area which will be devitalized by enucleation and which we want to maintain. Number three, if there are impacted teeth in the area which we would like to erupt. Number four, if surgical access is technically difficult. Number five, if the mandible is very thin and there's the risk of a pathologic fracture. And then also, very important in certain cases, in the medically compromised patient, the patient who is old or infirm and is not felt to be a good candidate for a larger procedure in a general anesthesia, but could have a short procedure done under local anesthesia. These are our indications for marsupialization. After we've sutured the cyst to the adjacent epithelium, the cyst epithelium becomes continuous with the epithelium of the adjacent body cavity. And it relieves the outward pressure of the cyst fluid, which is what causes the cyst to expand. The cyst fluid, just in this case here, is expelled into the mouth, and normal remodeling allows the cyst to start shrinking because of the loss of this pressure. So here we have a situation where we have a very thin lower border, some risk of pathologic fracture. We have an inferior alveolar nerve that runs through the cyst, so some risk of nerve injury by nucleation. And we have a tooth that we would like to bring into the mouth rather than extracting it, which we would have to do if we enucleated this cyst. So we perform marsupialization, and there is shrinking of the cyst and remodeling of the surrounding bone. So we see there's no longer a risk of pathologic fracture. This is all filled in with nice bone. We have a well-protected inferior alveolar nerve, which also has no tissue around it. And then we have to decide how we're going to normalize the situation here. I would suspect that now that there's no risk of pathologic fracture, the third molar could be removed, and either the second molar will erupt normally, or we could use some orthodontic treatment to help it erupt. Again, no free lunch. There are some disadvantages to marsupialization. One is that we leave pathologic tissue behind. And I'll mention this again in a minute. Two is that it can be inconvenient for the patient because the opening has to be kept patent. I'll get into this. And the third is that in many cases, a second surgery may be needed. In some cases, the cystic cavity just completely remodels and turns inside out and goes away. But in many cases, the shrinkage is slow and the patient wants to get rid of it. So after there's no longer a risk to adjacent tissues or for a pathologic fracture, we can go in and do an enucleation. So there may be a second procedure needed. Now, regarding leaving pathologic tissue behind, when we do the marsupialization and remove part of the cyst wall, we send that to the pathologist, of course, and get a diagnosis. However, as you know, not all cysts are homogeneous. For instance, there can be unicystic ameloblastoma with an ameloblastoma growing in part of the cyst wall. There can also be malignancies growing inside of otherwise benign cysts, and there can be other odontogenic tumors that are partially cystic. So, I've had instances where I've done a marsupialization for a large lesion. It's looked cystic. The part I've sent to the pathologist showed an odontogenic cyst. But over time, instead of the cyst shrinking, what I see is a tumor mass blossoming up out of the window of the cyst. Biopsy that, and it turns out to be, for instance, ameloblastoma. So we do leave pathologic tissue behind when we do a marsupialization, and it could be that later we would find out that we're not dealing entirely with an odontogenic cyst. Now, regarding keeping the window patent, what happens is that over time the window tends to shrink, and it can completely close up and a cyst can reform. And therefore, we like to keep the window open. In fact, we always keep the window open. So here we have a patient which I've created a surgical window into a cyst in the posterior mandible in the second and third molar region. And I've made an obturator which will hold that cavity open. And the way I've done it is with a lingual bar here with a little ball clasp that fits on the teeth, taking an impression, and instead of having the acrylic obturator going all the way down into the lesion, I incorporate a little plastic tourniquet tube into that. And the reason I use, not plastic, but rubber tourniquet tube into that. And the reason I use that is that as the cystic cavity shrinks, I can use the scissors to cut away the end of the rubber to allow the cavities to slowly shrink. Okay, so it makes things a lot easier. This is removable, so the patient can use a syringe to clean out the lesion, keep food from getting inside, and of course to clean the obturator as well. So this is what it looks like with the obturator in place. Here's the end of the plastic tube going down into the marsupialized cavity. Here's the little ball clasp holding it in place for the patient. So it's just as comfortable as a mandibular retainer can be. I mentioned that sometimes we have to go back in and enucleate, and this combines the advantages of both procedures. We decrease the size of the cavity and reduce the risk to adjacent structures, and then go ahead with enucleation. So a situation where there's a fairly large cystic lesion which encroaches on the lower border, which involves the inferior alveolar nerve. We can see root resorption of the second molar, and we have this impacted third molar in the lesion. Certainly, enucleation of the lesion would require extraction of the third molar, and the force of extraction could lead to a pathologic fracture in a case with a very thin lower border like this. In addition, there's some risk to the inferior alveolar nerve and a risk to devitalizing the second molar, which already has some root resorption, but root resorption doesn't mean devitalization of the tooth. At any rate, I marsupialized this, and after 6 months, you can see that the cyst has gone down to just a small lesion, which looks like a normal enlarged follicle around the crown of the impacted tooth. And we can remove this tooth now with little risk of fracture and little risk to the inferior alveolar nerve, which has bone around it now. Okay. So we'll move ahead into treatment of benign tumors. Solid tumors, when they're small especially, can be treated in a similar fashion to the way we treat cysts. And certainly the factors to consider are similar: size, location, mandible versus maxilla versus soft tissue, relationship to adjacent structures that we would not want to injure, the aggressiveness of the lesion, and the need for reconstruction after removing the lesion. As with the cyst, enucleation of a benign tumor is possible in tumors that are encapsulated. In other words, they are surrounded by a fibrous capsule of non-pathologic tissue, with the pathologic tissue being entirely within the fibrous capsule. And we remove the tumor in one piece. We can also do curettage, and that's removing the tumor by scooping it out or drilling it out of the bone. And we do this especially with non-encapsulated tumors, where there may be some extension into the surrounding bone marrow, and we want to remove some normal tissue with microscopic abnormal tissue at the periphery of the tumor. As with cysts, we can combine the two. We enucleate the tumor in one piece, and we follow this with a peripheral ostectomy, or in the case of a soft tissue tumor, with an excision of surrounding soft tissues to eliminate any additional tumor cells beyond the obvious margins of the tumor. There is an increased risk to adjacent neurovascular structures, teeth, nasal and sinus cavities, but it definitely decreases the incidence of recurrence when we're dealing with an aggressive tumor or with a recurrent tumor, which may not be felt to be aggressive, but which has shown us that it's biologically aggressive because it has recurred. Some tumors require resection. So we have to remove the tumor with a geometric piece of tissue surrounding the tumor. This includes both bone and soft tissues, and this is appropriate for aggressive tumors. For aggressive tumors, we don't want to go in there and be scraping at the tumor, either by enucleating or curetting the tumor, because we can cause it to spread or to leave cells behind microscopically. We want to make sure it's completely contained in the block of tissue that we remove. So here's an ameloblastoma of the mandible with invasion of the overlying gingiva, and we have to treat this more aggressively with a resection that you see includes both bone, gingiva, and adjacent floor of mouth and labial mucosa. In the case of a tumor involving the alveolar process of the mandible, there's a special segmental resection called a marginal mandibular resection. And this is a resection that takes off the alveolar margin of the mandible, leaving behind the lower border for continuity and strength of the mandible, and depending on the size of the lesion, also missing the inferior alveolar nerve, so you don't make the patient numb, even though you take a nice block of tissue for our segmental resection. And here's a panorex of a patient with a marginal mandibular resection. We can also do a partial resection for larger tumors, and that's removing a segment of the mandible, including the lower border, so that we're leaving behind a gap. This definitely requires reconstruction, something we'll speak about in the next hour. So here's a partial resection. If you look here, you can see the ramus and condyle of the mandible, which has been pulled up under the zygomatic arch by the unopposed pull of the temporalis muscle. And when we reconstruct, we have to bring it down and put in our bone graft here. Soft tissue lesions can't be ignored. Generally, they lend themselves to a simple surgical excision. So here we have a skin tumor. This white area is because of injection with local anesthetic with epinephrine. And here the tumor is excised, and I've developed a local skin flap. We'll get into flaps a little bit later this morning. Here the wound is closed with the flap, and the donor side is closed as a straight line. And here we are after about 6 months. Okay, so a very nice result. Another soft lesion we'll treat sometimes are keloids, which are sort of soft tissue tumors of a scar. Keloids can be managed a number of different ways. I won't get into that in this talk, but we can treat them very, very nicely. Another soft tissue tumor that we will treat occasionally. A number of soft tissue tumors of the skin and mucous membrane can also be treated with coagulation. In order to do this, we may use heat or cold or various chemicals. These lesions would include premalignant skin lesions like actinic keratosis. They can include angiomas, hypertrophic scars, mucoceles, pyogenic granulomas, and others. Often there's healing without a scar. These things can work very, very nicely. So here's a patient with a viral wart treated with diathermy. Very nice result. Here's a patient with a pyogenic granuloma of the gingiva, treated with liquid nitrogen. And here's a patient with a vascular lesion of the skin. Vascular lesions can be treated with embolization if they're caused by large vessels. We'll get into embolization in a bit. They can be treated with camouflage. That's by tattooing them. So there are actually medical grade tattoo needles, and you can tattoo over this area with white pigment and cause it to be a more normal looking pink area. But nowadays, the most often treatment we use for this is coagulation with a laser. And here it is treated with a pulse dye laser, which causes the small blood vessels in the skin to coagulate, and we get a very, very nice result by treating these vascular lesions with laser. Okay. Any questions? All right. I was hoping there'd be something, so I could take a little rest.
I had a quick question. So
Yes.
you talked about how I think it was a soft tissue lesion near the eye. Removing that could be difficult because it could pull the eye and suture it up. How do you
Yeah,
avoid?
the skin is very thin and can be pulled very easily.
So is there a way you can avoid pulling the eye, or is it inevitable?
You avoid pulling the eye by the way you design your excision, and sometimes, depending on the size, you have to reconstruct with a flap, which I'll be talking about soon, by bringing adjacent tissue into the area so that you don't pull on the eye, you pull on the adjacent tissue.
That makes sense. Thank you.
When you're doing a fine needle aspiration, how do you know that you're in the lesion?
When you're giving an inferior alveolar block, you're injecting next to the inferior alveolar nerve.
Just based on like location and how the needle like falls into place?
Well, as with giving an inferior alveolar nerve block, it's with location, but in addition, you're sticking the needle into the center of a mass. Now, sometimes it's a cystic mass, so you draw back and you get fluid, and you'll say, "Oh my God, it's a cyst." This makes things easy, right? You diagnosed it as a cyst, and then you can go ahead and remove the cyst. Sometimes it's tissue and you have to send it off, but there is a little bit of a learning curve, but you're sticking in the needle into the center of a structure. As with the learning curve in giving an inferior alveolar block, you just eventually learn to do it.
Okay, thank you.
Okay,